One of the comments that you made during your presentation at FIP was that suicide is different and distinct from self-harm. Could you explain a bit more, please?
Yes, I was talking about self-harm and suicide being on a spectrum of behaviours. Some people self-harm for different reasons, so for regulation of emotion, because they have suicidal intent, they may be ambivalent, or it might be a mixture of all those things. So it's really quite a complex set of behaviours between, that could be self-harm, suicide attempt, and it's not going to be up to us really to be able to pick out where the person is there, and that's why having conversations with people is important. The reason I brought it up at FIP was in the context of the new NICE guidelines on self-harm and prevention of self-harm in adults, because some of the work that we did fed into that guidelines and is cited related to the role of community pharmacy teams. So pharmacy teams are now being recognised nationally to have a role in having conversations with people about self-harm and also understanding their medicines access, some of which has got different levels of research around means restriction.
Thank you for explaining that. Now, I've recently learned that the expression "to commit suicide" is no longer considered appropriate. Could you explain a bit about that? And also, could you talk to us about stigmatising language in general and what healthcare professionals need to be aware of?
Until 1961, suicide was illegal in the UK, and sadly it remains illegal in some other countries still. So this is where this word committed has come from, because it has connotations of crime, and that's not how we want people to feel. So the phrase "died by suicide" or "die by suicide" is preferred. With a sort of the wider language around suicide, different people will have different preferences, so it's about understanding how the person would want to communicate about that. The key message is that using the word suicide is okay. It is okay directly to use the word suicide, and that is perhaps encouraged actually by some of the mental health charities. In our research, some of the comments that were made the pharmacy staff making the comments are very conscious of the stigma might still exist around suicide and mental health problems. I do think it's improving, but I still think there's some way to go. And sometimes there were accidental implicit comments that had sort of perhaps pigeonholed people into certain groups, and we have to be quite careful there, obviously because of the stigma point of view, but also because suicide risk assessment is a very difficult area. So there's evidence to suggest that completing a risk assessment kind of checklist is no better than a clinician that's a specialist being able to assess suicide. So I kind of want to caution people away from being really hung up on sort of risk factors, so to speak, and actually taking each person and conversation, behaviour change, etc. as it comes.
Those are useful points. So what does all this mean for community pharmacy teams? What could they be doing?
I think the first message is not to be scared, and we're not trying to overwhelm pharmacy teams. This is about having the conversations that actually people are already having with their customers, clients, patients, but perhaps in the safest and most effective way. So it is okay to use the word suicide and ask people about suicide. And there's some nice resources on both the Mind and Samaritan's websites that can help people with those sorts of phrases. And obviously the Zero Suicide Alliance training that we previously talked about. And maybe practicing having those conversations might increase people's confidence a little bit. What's come out of all the research is in the importance of thinking about triage and referral and signposting to services. And people working in pharmacy do this all the time, but it's about thinking about what might those best services be. One useful resource in the UK that some people may not have heard of is called Hub of Hope, and that's a resource that enables people to search by postcode for relevant services to do with different mental health problems, but also some of the wider societal problems or personal difficulties that people might be facing to help signpost. And I could almost want to coin like a micro local kind of referral pathway, because actually, if you imagine you have someone coming into your pharmacy that's quite distressed, start sending them off even 2 or 3 miles down the road might be quite difficult for them. So thinking about what really is in that person's community, but also remembering perhaps online resources for some people might be suitable, or remote resources, telephone resources, for example. So those are the first 2 things. And as part of the signposting, I would encourage people to explore the local systems. So things like the primary care networks, the integrated care boards and systems that are now prevalent, so that people can understand how they can work across sectors and together.